camera. Let's see this camera.
Oh, thank you.
It's working. Okay, it's working. Go.
Thank you.
So,
Okay, I'm going up to get a printed page. Let's see, where did I put my keys?
hello.
I did.
Brian's not going to be here, so.
He's not?
No. home, it's late, so
Oh,
you're gonna be the, yeah.
it's gonna be me again, huh? All right. You gonna call in at least?
No.
He's not even gonna call in?
No.
You just like check it out.
It's on, yeah. It's on the end. You're gonna close it out.
Yeah.
No one signed in. Oh my God. Ugh. So we have 0 people joined.
Well, we're still pretty early.
Yeah.
Not too early, but you got your boots here anyway, huh?
That's it.
Oh, that's camp.
Yeah.
Ah, got it. I was gonna say, they looked a little bit big for your feet, but,
Yeah.
oh my.
Slow.
Yeah, I think everybody's a little slow. It's seasonal.
Like back to winter.
Yeah, I paid somebody to put a lot of grass seed down for me last week.
Oh.
I hope it didn't freeze off or die, but
Yeah, usually, they said, oh, you want to do that in April or something like that. Now it's April, it's still snow.
yeah. Yeah, it'll work though, I think, I hope. Mountain Dew, huh? Or is that? Yes. Alex. Campbell, okay. Yeah, I'm all tired. Okay. Where's the change for me when I'm opening Finder and I'm getting, it opens a new window every time I click on a folder? Where do I change that?
On your laptop?
Yeah. I know it was one thing and then I changed it this week and I don't like it because it's opening every time I open a Finder. Then I go to documents, it'll open a new window. I don't want to do that, so. I don't know.
That's honestly, it doesn't.
Yeah, I know, and I set it, maybe it's, no, where did I set that? Folder search options,
Go to double click open item, single click.
show all, automatic restore defaults, maybe I'll just restore defaults.
Yeah.
Yeah. There we go.
Oh, it's right here,
That's
open,
it.
yeah, it's that open each, there you go. So,
Yeah, oh boy. So we have a different, this will need to go up in chat.
wait until you get Windows 10. You have Windows 10 at home, do you?
No, I don't,
Okay,
I'm not
yeah.
a Windows person, I'm a Mac.
Yeah, and then Windows 10 gonna be like, even worse than Windows 7.
Really?
Yeah, it's all tired. I don't know, it's weird. It's like you can't find what you need to look for.
Hello,
Hey.
Pam, how are you?
Good, how are you? So I'm running the deal again?
Oh,
Okay.
I mean, he might be on.
Is he, everything
Yes,
okay?
Yes, he has a sick kid that's actually feeling better, so he.
Okay.
Whoops. Oh, that
it going?
Oh, hi.
Hello, everyone. Hey. Hey, guys.
Hello.
Hello, everyone.
Sorry, we got. Oh, I got a hot mic.
Can you mute your computer?
There we go.
Can you hear?
Kelly, Nate, how are you?
Good. How you doing?
Oh,
Great. Excellent.
Good.
Is Roxanne there?
I am
She is.
here. Yes.
Great.
Let's
Hey,
see.
Roxanne. Is Charlie back today?
No.
Okay. And
I think-
yeah, I did get
Wait.
your message. Brian's really busy and everything, but you know, if they do get a chance, maybe they could shoot me an email sometime. That'd be great.
Yeah, I know, Brian has a sick kiddo at home today, and actually, the good news is his son is feeling better. The bad
Yeah.
news is his son is so chatty that he doesn't know that he can, join us at Echo.
Okay.
So,
me too. Yeah. And like riff on stuff if you want. You know.
Sure. Let's do it. I hear you.
okay, let's see. Keep you guys in the focus.
Okay.
Oh, you sat in a different place. You gotta just change your,
Who, me?
yeah.
I didn't look.
Well, I just
Went autopilot.
put that, doesn't matter. I think Alex is coming in person, but.
I think this is a great case.
Yeah.
Okay.
This is something we talk about like on drug court all the time. You know, we have people with ADHD, maybe they are not on
Mhm.
one of the medications, and then people aren't doing well. All of a sudden the appeals and everybody kind of comes around to maybe we should give them an ADHD med, maybe,
Right.
you know, and at first there's kind of that universal skepticism that that population of people hasn't responsibly interacted with providers in the past.
Right.
Maybe they haven't been responsible providers in the past.
Mhm.
So everyone's kind of hesitant, but in some cases it's like even the most skeptical group can come around to it.
Number 35, Echo.
Hey, Cam, Nate, Roxanne.
Yes, hi.
You're Dale here. He's a.
I'm sorry, I didn't hear that. Say again.
Eric Dale is a college clinic, and we're seeing a lot of patients, and he's able to provide some, you know, behavioral health type counseling and other services, and so we're kind of branching out and kind of looking into that. As you know, we had some turbulent times earlier this month, but all is smooth sailing now. But
Well, good.
in a nutshell, this is probably going on in a lot of clinics. That is to say, other clinics are probably being visited, and there's probably information, you know, that they want to know. And as soon as they get all the information they need, they'll they're just through some of the situations. Eric is here. He's helping us out, and I want this visit the ECHO program to observe what's going on, and I think he's really excited about it. Yeah.
Great.
Well, welcome.
Thank you.
And would you just put his name in the chat box? Because I didn't quite catch it. You're kind of breaking up with your sound.
Sorry, yeah, Eric Dale. Mm-hmm. Yeah.
Okay, great.
Okay.
Hey, glad things are looking better, Dr. Dodson.
Yeah.
And Eric, I'm sorry, I missed, did you say that you're a psychologist?
Correct. Yep.
Okay, great. Where have you been, are you there full-time or?
Yep. Currently, I'm here full time. Correct.
Okay. And how long have you been there?
About 2 months.
Okay, great. And doing mostly like CBT for chronic pain stuff, or?
CBT interventions, and then doing assessments where we can for PTSD and other variables.
Say that again?
Doing assessments for PTSD and other psychopathology when available.
Okay, great.
Hi, Valerie. Hello.
Hey, good to see you.
Thank you.
Good vacation?
No, I was sick. I lost my voice.
Oh, that's right. That was last week. So your vacation was 3 weeks ago or something,
Yeah.
wasn't it?
Yeah, spring break. We should be springing now.
Right.
But it turns out it's actually a break from spring and we're still breaking.
Yeah.
Hey, so Rox, I had an idea about, so you guys want to kind of summarize the recommendations from the team. What if we had a clipboard and it had a piece of paper and it had a few blanks, like few recs.
We wrote them down before we left.
Yeah, like that we could kind of pass around, like something that we can do in real time. Like we might jot down one or two things. You have it all in one thing, and you could either email it or fax it. You know, like log it. Like,
yeah,
it has to be because I.
The jails and stuff like that. That's exciting. There's a coordinator. Is that sound up already? Yeah, that's right. Yeah. Mm-hmm. Cameron, he's a psychologist.
Does he work with the state?
Yeah, LEDC works with the state.
And Cameron too?
Yeah.
Okay.
Yeah. It's usually run by Brian Graham, who's the top MD, and then Charlie Restikoff, who's another MD that they do the addiction and pain management. But this branches off into a lot of different areas, so it's kind of exciting.
Interesting.
Good thing is I get credit for every single time I sit for the 12, 15, 1, 15, I get 2 credits, and also I can kind of brag to the fact that we're working with this group, and I originally presented here, and so they basically gave me the information of what they would do, somehow to by approximately 10% every month, you know. And so when I go in front of the 26, echo and
Hi, Cam. Hi, Nate.
Hi.
Hey, good to see you.
Everybody in Hennepin.
Oh, there he
Hey,
is.
Kurt.
Are you guys back home or are you traveling somewhere again?
We're working. We're back home.
Oh, okay.
So you guys usually work when you travel, right?
Oh, yeah.
Constant work.
Yeah, right. Yep.
Try to work all day and all night if we can.
That's right. Yep.
Where's Brian?
He's got a sick kiddo at home.
Oh, okay.
Yeah, so he may or may not be trying to call in. He's not sure yet.
Okay. Well, we've heard Nate talk before, but we figured we'd come on and refresh ourselves since it saves lives.
I don't know if it, I don't know if
Yeah,
we can
no
go that
pressure.
far.
No pressure. Yep.
But
Save
We
lives
might
today.
be able to use our expertise for the case.
Mm-hmm.
right.
Oh, we could, yes.
We're gonna blacken out, but in the case, we'll come back. We'll listen and then we'll come back and work the case. What's the case about today?
28-year-old female with kind of polysubstance, but the question is regarding her ADHD diagnosis and
Is her name Heather?
Yeah, Heather, we're gonna need you to earmuffs on this one, okay?
I'm just
Okay.
glad you didn't say Helen.
Yeah.
I'm not the one with this in front of me.
Yeah, no personal
You leave
health
him alone.
information, but this is Heather.
You leave him alone with that Diet Mountain Dew thing. It's perfectly acceptable.
Yeah. All right. We'll come back to the deal
Okay.
later.
Sounds good.
Well, feel free to interrupt during the lecture too. You guys always have tons of good questions, so
Yeah.
don't hesitate to do that.
Yeah.
Oh, so you want us to harass you?
Well,
Right. Yeah, you pretty much got that right.
Something a little less than harass, something just below that level.
But
Okay.
really, walk the line. I mean, don't go
That's
too
your
far
job,
below.
Cam, to walk the line.
Yeah.
Um,
All right.
I'll bring my boys on and let them harass you.
Awesome. All right. So we got Alex on. He must. With Alex, we thought you might be joining us today, but you're remote, right? And Deodane, am I saying that right?
Oh, is my mic on right now?
Yeah.
Oh, great. Yeah, sorry, I had to stay home today. But thanks for having me.
Okay. Yeah. Great.
Thanks, Alex.
Yep.
Yes.
Okay.
You saying it right?
Yes. Diodone.
Deodane. And you're calling from Northeast, right?
Yep.
From Northeast, okay. And Audrey is on. Hi, Audrey. There she is. Hi. And we got Peter. Hi, Peter. Who's with you today? Peter's working on the microphone.
I can unmute him, perhaps.
And-
Okay, oh, no.
oh, there we go. Hi, Peter.
Hi, how you doing?
Good. How are you? Who's joining you today?
Oh, this is Heather Keenan, who is, how would you, let's see, she's in our marketing department, but she's interested in learning about what ECHO is, and so I asked her to sit in. I hope that's okay.
Well, absolutely. Of course. The more the merrier. Welcome.
Thank you.
Yeah. So I'm Cam Weaver. I'm the clinical psychologist on our ECHO team. Our lead, Brian Gran, who is our addiction medicine doc and kind of the project lead, is out with a sick kid today. So he may or may not be calling in a little bit later. Just kind of depends on what's going on at the home. Yeah, welcome. Yeah, feel free to ask any questions or comments. And Brandon Anderson. Hi, Brandon.
Hello.
Hi, where are you calling in from?
I'm calling in from Red Lake, Minnesota.
Red Lake, great. Thanks for calling in.
What do you do in Red Lake, Brandon?
I am a clinical pharmacist.
Awesome. Oh, excellent. Welcome. And we got Jody from ICSI. Hi, Jody. Hi. Yeah. And Raymond Christensen. Hi, Raymond. Where are you calling in from, Raymond? I can tell from outside your window it's Minnesota.
Yes, no snow yet.
Yeah.
Lots of wind.
Just no snow?
Not yet.
Oh, not yet. All right.
40-mile-an-hour winds off the lake.
So you're
Big
calling in
waves.
from Duluth then, right? Okay. Yep. It's headed your way. All right. And then let's see. Sarah Ames. Hi, Sarah.
Hi, I'm sorry that I don't have a video. I'm calling in from the pain clinic at North Memorial Health.
Oh, great. Welcome. Yeah, welcome. Thank you.
Thank you.
And Valerie from Minnesota Recovery Connection. Hi, Valerie.
Hello.
Thanks for calling in. And then, is it Katie Logue?
That's Kelly.
Is it
Kelly Light?
Kelly Logue? Is it Kelly Logue, right?
Yes.
Hi.
Yes, Kelly Logue from Health Partners.
Yeah, hi. Thanks for calling in again. And then Natalie Hayes from Richfield Clinic.
Hey, Natalie.
Hello, I got married 1 week ago today, but I'm keeping the name Hayes, so.
Okay, well, congratulations.
Congratulations, Dr. Hayes.
Thank you.
That's awesome. We got a couple of people who are logged in through their phone lines, and all we have is their phone number. So If you are one of those people with just your phone number, if you have access to the chat, you could throw your name into the chat at least.
Probably don't.
Probably don't. Okay. Maybe. So I'll just do it the last four, so we don't give everybody your numbers, because Heather Bell from Little Falls will definitely prank dial you if I give you the whole number. So whose number ends in 1089?
Wait a minute, I'm writing it down.
I'm only giving you the last four, Heather. 1089. I feel like I'm like reading bingo or something. All right. Well, 1089. Welcome.
They're actually
They left. I scared them away because they didn't want Heather prank calling them.
Okay.
What about 3912? Who's got the number 3 with the ends in 3912? They're not muted. I know they're there.
So if they can just send Roxanne an email by,
Yep.
to get some credit, that would be helpful.
Yeah.
And
Wow.
Tri-County, who's from
Yeah.
Tri-County?
Yeah. Who's Tri-County? Hi, Tri-County. Who do we have from Tri-County?
Boy, we're kind of striking out.
Yeah, we are. Maybe they're having trouble with getting their muting to unmute.
Sorry, if I.
Oh, Natalie is 1089. Got it.
Natalie is, okay.
All right. Audrey. Oh my gosh. Taysa from the Mother Baby program here at Hennepin. Hi, Taysa.
Hi.
All right.
A lot of videos missing this time.
Deanna Moncour. Deanna. Hi, Deanna. Deanna, where are you calling in from?
Let's get it rolling.
Yeah. All right. Well, welcome to all of those who I haven't had a chance to say hello to. Sorry if I missed you, but we should probably get this thing going. We have a really great case today that Alex Hubo is going to present. But before that, we're going to actually do a bit of a revisit of one of our talks that we gave earlier in the Echo. It's probably like Echo number 2 or 3 or something. It was pretty early on. And so every once in a while, because our community is growing so much and so fast, we thought that it'd be good to kind of go back and touch on some of those topics. So a little bit of a review. Just a couple reminders. If you're not asking a question, please mute yourself on your end. It's a lot easier for you to mute yourself and then unmute yourself to ask a question than it is for us to mute you. But if you can't get your mute to do its thing, we can mute you for you. Remember, this is a personal health information free zone, so no PHI, please. We love that so many people are calling in. There's lots of names on the screen right now, but as much as we like your names, we love your faces. So please feel comfortable if you have the capability to call in via video. We love to see you. It just really helps us kind of interact and feel a little closer. If you do have a question, like I said, you can unmute yourself and just ask. If you're on video, you can just kind of flap your hands wildly. That'll get our attention. Or, of course, you can hit the little icon in down on the bottom of your screen, probably, where it says question. You'll raise your hand icon. Or alternatively, you could just type something into the Zoom group chat that we've already got started. Final thing I'll remind you of before we get going here is if you have anyone in your room that we don't know about, make sure that you put their names on the group chat so that Roxanne can make sure that they're getting their credit for being here. Upcoming echoes, we got Dr. Kaz Nelson coming to talk to us about borderline personality disorder next week. It's going to be a great talk. After that, we don't have an echo. Addiction medicine here is doing grand rounds, and so our efforts will be focused on those grand rounds that week. So no echo on the 25th. And then after that, we're trying to kind of make a plan. We're not sure what that's going to look like, but to be determined. Also, our colleagues up at Little Falls who are yep, they're still on. Good. Have a couple of great talks coming up. Haley Powles, who's no stranger to our Echo, is also going to be doing a presentation for their Echo with the unconventional misuse of medications on April 17th. And they also have a no Echo the day before our no Echo on April 24th. with future talks, I'm sure either planned or to be determined as well. So without further ado, I'm going to turn it over to Nate, who's a licensed alcohol and drug counselor here, both at Hennepin and working through drug court. And he's going to give a brief talk on motivational interviewing as a bit of an introduction to the process.
Thank you, Cam. Yes, absolutely. And I invite you all to interrupt and ask questions throughout this lecture. The kind of the beauty of this system here, this Zoom system, is that you can do that. So feel free to ask questions if you like. And we do go till 1:15, so we'll try to do about 20 minutes or so for the case at the end. So we'll just kind of all keep track of time, and depending on the questions that come in, we'll try to wrap this up in about 20 minutes. Okay, where to start? I think it makes sense to start with the sort of axiomatic presuppositions that underlie this whole thing. That sounds fancy, but I think this stuff, this early stuff, there's lots of words on the screen. This is the sort of bedrock that motivational interviewing sits on as an idea. And I'd like to start with Carl Rogers, but maybe we can go back to Freud a little bit. So if you think about maybe like Western intellectual thought in general, you know, Freud pops out and brings attention to the unconsciousness. And this is not something that was commonly talked about, this idea that there are portions of yourself that you're not aware of that might be, you know, doing things that you don't have access to. And the Western, sort of the ideas in Western thought at that time was very empirical, very science-based. It wasn't, this is kind of a revolutionary thing. And just the idea of a talking cure in general for some of these mental health symptoms, not the language they would use back then. Freud's a big deal, right? I think it's kind of trendy to bash Freud, but he's a revolutionary, and we're all kind of like still working with a lot of his ideas.
I'm happy to bash Freud with anyone later if you'd like. Just
so Carl Rogers comes along, right? He's got a totally different set of assumptions. Freud is saying you have some unresolved conflict from childhood. We need to do some psychoanalysis. We need to go back there and analyze what's happened, and that through this analyzing with an expert, you're gonna, you know, live a better life. Carl Rogers is saying something entirely different in my point of view. He's saying people have an actualizing tendency. And what what he means by this is that people tend to get better. That if you let people sort of run the course of what they're doing, if you let them talk about what's going on with them, they're gonna trend towards solutions to their problems. And it's not some sophisticated sort of analysis of your childhood that's going to lead you to a better place. It's this sort of natural tendency that unfolds. Carl Rogers is, I think, the foundation. Well, it's person-centered care. Whenever anybody says person-centered care, in my mind, what they're really talking about is Carl Rogers. And here I have, and I know there's lots of text, but these are the main concepts. And I took this from one of the writers of motivational interviewing, actually his book and this Norcross Fellows, Systems of Psychotherapy. This is, if you condense Carl Rogers down into 3 bullet points, I think you'd come up with this. This is basically motivational interviewing. And my next slide will be the language of motivational interviewing, but you'll be able to see how this exactly dovetails with motivational interviewing. So let's give Carl Rogers his due and kind of and sit with him for a little bit here. And I'd love to hear what you think of this, Cam, or anybody else. But this first bullet point, this is a big deal. Therapist congruence. How do you create a sense of authenticity when you're meeting with a patient? You have to be deeply involved. You can't be acting out. You have to actually be interested in what the person is telling you. Not easy to do, not easy to describe, but if you sit down with a patient and you say to yourself, this person is going to tell me something that I need to know, then you're generally in the right place. Then you're generally listening in the right way. If you're not thinking about what you're trying to respond with, if you're not thinking about, I don't know, what's going on at home, but you're just actually sitting in the moment with a person and saying to yourself, they're going to tell me something I need to know about them, I think you're generally in the ballpark. And then the last sentence here in this first bullet point, self-disclosure. I think self-disclosure is an important tool that we're all going to have to use to some extent for patients. And you don't often hear people talking about what are the guidelines or rules for self-disclosure. I mean, I don't hear people commonly discussing this, but I think it's like a big deal in what we do. I think one possible guideline for self-disclosure is disclose things that further the relationship with the patient. So if you're talking about something to get something off your chest, and it won't help the relationship, that's probably not the right thing to be sharing. But if you're sharing a detail of something about yourself that is going to further the relationship with you and the patient, that's going to draw the patient in, help the patient understand that A, you're listening, and B, you can empathize, then that's useful self-disclosure. So authenticity, therapist congruence, hugely important. Self-disclosure is a part of that, and I think it makes sense to think about what we're doing with self-disclosure.
Yeah, I think self-disclosure is always kind of, I think of it in a couple ways. One, it varies a lot among providers and what they're comfortable with, but you should also consider the patient as well. Some patients, self-disclosure, I think, is relatively safe practice, and other patients it may not be. So patients who have psychological disorders that maybe are more prone to manipulation and intrusion, those some types of self-disclosure may kind of be counterproductive. But in general, as Nate said, if you're using self-disclosure to highlight a specific point or to improve the therapeutic relationship, I think most importantly on your terms, can be really effective tool. Yeah.
I agree with everything, and this is Helen Wood, psychiatrist. I would also add, if you have a patient who has a lot of cognitive distortions, or if they're really psychotic, they really may misinterpret anything you say, so you have to be really careful what you do say. But if you have a healthy, functioning person, and it helps them to know that, they're struggling with a lot of parenting issues. This is really common. A lot of my patients see me for postpartum depression. They really want to know that I'm a mom, and that's really helpful, and it reassures them and validates them. And so I agree completely that it really can.
A little can go a long way.
You can join with them and really move forward in the treatment when they have that power differential diffused a little bit, that you're on the same field.
Exactly. I couldn't agree more.
Yeah, self-disclosure takes practice. It's actually a skill that you have to build and develop. And there's going to be times when you get it wrong. Maybe you over-disclose, or maybe your hesitancy to disclose hurts the therapeutic relationship in some way. But everybody, you got to do what you're comfortable with, and utilize that tool just kind of based on that, I think.
Yes, thanks, guys. Exactly. Second bullet point here, unconditional positive regard. Everyone's probably heard that before. What do we mean by this? I think the key here is you're sitting with a person, you're not approving or disproving what they're talking about, right? You're sitting with them in a positive way. You're willing to hear what they have to say, but you're not agreeing. And I think this is key. You're not agreeing with what they're going through. You're not like co-signing it. You're not saying you are right to be depressed for the reasons you've laid out. You're saying, I hear that you're depressed for the reasons you laid out. I think that's a distinction that people often miss. Like, obviously, disapproval is not going to get you very far. But I think people, when they think of positive regard, lean towards the approval side, that you have to be approving of things that a patient's talking about. And to the extent that something a patient is going through, a negative emotion, let's say depression or anxiety, I'm not agreeing with the anxiety. I'm hearing that you're experiencing it, and this neutral place to discuss it is helpful, but I don't want to agree that situation should make you anxious or should make you depressed, especially if you're trying to work your way away from that, not be so bound up by that depression or anxiety. So, yeah, I mean, you guys can read a little bit more about unconditional positive regard. You could just talk about this for days, but so important to sit with people in that neutral and positive way, and not be judgmental.
Yeah, I think too, unconditional positive regard. I think, like Nate said, the tendency is to think that you just have to just really like everything about your patient in order to have that unconditional positive regard, and that's not necessarily true. What is true is that if you're able to find the good in the patient, if you're able to project to the patient a sense that you're going to be there in that room with them regardless of what they say or how they say it, I think that's important, because really what that comes down to is trust.
And safety.
And safety. Patients are very vulnerable when they're coming to you and they're discussing their lives with you. And if they do feel judged, oftentimes, depending on specific diagnoses, you might find that they come from homes where unconditional positive regard was not modeled. A lot of their self-worth came from acts or came from some kind of conditional positive regard where love was conditioned upon certain behaviors. And so modeling that is not where this person's esteem and self-worth comes from can be really helpful in getting them to feel disarmed and comfortable speaking with you.
I mean, I was just going to mention that I was thinking the same thing, is that this may be the first time your patient has had a relationship with unconditional positive regard, and their experience may have been unconditional negative regard throughout their life. And so this can be quite extraordinary for them to be in a positive relationship with the provider.
I agree. And do you guys ever find that early in your meetings with patients, the first few sessions, oftentimes they're sort of like cautiously exposing elements of themselves that they think you might judge, and that your reactions to those are just so key in the first few sessions. Like, oh, you told me that? That's fine. Let's keep going. What's the next?
And like as if to test you, to see if you can tolerate hearing how broken they are or how troubled they are, and are you going to be okay?
Absolutely.
Yep.
So this is happening right away, especially. Yeah, I think this is super key. And then third bullet point here, empathic understanding. I'm just going to roll that into the second bullet point. Empathy is good. It's not approval or disapproval. You have to be able to conceptualize what it would be like to be that patient. Someone's telling you their story. You have to be able to imagine that that's the reality. You have to be able to accept some things about your patient. That's not approving or disproving. It's just understanding. Does that make sense?
Yeah, I think one of the things it's no surprise that you cited a work with Norcross in there. Norcross is also known for research on looking at what we call common factors in therapy. So there's this huge push for empirically supported treatments and evidence-based practice. But when you look at those studies, while they definitely show efficacy, and we should be kind of looking at interventions along those lines, and I certainly follow evidence-based principles of behavior change and using evidence-based practice in my everyday work. It's also important to note that those studies don't account for all of the variance explained in positive outcomes for our patients. There's a good chunk of variability not explained by the specific intervention, and that chunk is sometimes called by Norcross and others as common factors, which includes a therapeutic alliance. And so what Rogers really did, I thought, was revolutionary, is he was able to
Hey, Haley, we can hear you.
Sorry.
No problem.
It's okay. Haley's just shuffling some papers.
Just working.
So what Carl Rogers really did, beyond having a really effective therapeutic style, is he really set the tone for what those common factors are and what they should look like, and what that things like the therapeutic alliance that you have with someone and how to develop that is a way of explaining more of the variability in patient outcomes. So
Rogers is a big deal.
Yeah. Agreed.
So everything we just talked about, this is basic motivational interviewing language here, 101. Engaging, focusing, evoking, planning. This is what they're telling you to do. If you look at the language here, it's basically Carl Rogers. I think motivational interviewing is great, as a package or as a marketing kind of thing or for trainings. But motivational interviewing for me owes 80% of its conceptual base to Rogers. So you guys can just think about that or agree with me or not. Engaging, the process of establishing the working relationship. We've already talked about that. Reflective listening. We haven't mentioned that yet. That's coming up. Client and counselor make agreement on treatment goals, collaborate. So you want to seek and maintain direction. This is focusing. Evoke, you want to get the patient ramped up and eliciting their own motivations for change. Try to get a sense of their values, their, what they really want out of their life. And then lastly, make, plans around that.
And I would add, like, Carl Rogers is kind of the backdrop, but I think there's a couple of other theories that play into motivational interviewing too that I don't think often get a lot of attention. And that's, if I'm going to add Carl Rogers' name to influencing motivational interviewing, I'm also going to add Bandura's name, social learning theory. So addressing kind of the learning aspects of cognition and helping to kind of recognize like the whole idea of developing a discrepancy and causing cognitive dissonance for an individual to help motivate them towards change. That's Festinger's work. And then
Who, Festinger?
Festinger, yeah. And
I
then
need to look that up.
Yeah,
'cause
and
I
then,
do that discrepancy thing all the time, but I don't know who started that.
Yeah. Well, cognitive dissonance, I guess, it's been coined, you know. And then I always have to give a shout out to B.F. Skinner, actually. I think that a lot of evoking for patients, it's not just about, which we're going to get to here in a second, eliciting change talk. It's when you hear that change talk, reinforcing the hell out of it. And so there's a very strong behavioral component to motivational interviewing as well.
It's different than Leonard Skinner.
It's B.F. Skinner, not Leonard Skinner.
Okay.
Yeah. Don't get those confused. Don't Google, you know, Leonard Skinner and behaviorism. I don't know what would pop up. It could be dangerous.
I don't think I go quite as hard on the CBT as you, Cam.
I know.
You know, I don't like to give those behavioral therapists their credit, but.
Well, and that's why we're a good combo.
Yeah, that is why we're a good combo. Okay, so here's the trans-theoretical model. This is rolled into motivational interviewing. I kind of separate this out a little bit. And the backdrop for that is New Mexico, by the way. Right outside the Echo training.
That was our hike.
Okay, so what is the trans-theoretical model? This goes along with motivational interviewing, Carl Rogers stuff. You're going to do all that, identify goals, elicit change talk, all that good stuff. This to me is one of those axiomatic presuppositions that I think people don't like. This has to be your worldview, in my opinion. You can't imagine change as a linear progression from point A to B, in which you're upset, disappointed, or somehow put off by something that doesn't just progress linearly. So if you have a patient who's doing well one day, maybe they're abstaining from use and their UAs are negative, and all of a sudden they're positive, they're using maybe this, you know, who knows what they're doing. To not be upset by that or thrown off, I think is key. I don't know how I would do my job over the last, 10 years or so I've been a drug counselor without knowing this and being comfortable with this, that when people make change, they're not going to go from point A to point B universally in one direction. If that happens, that's great. Most of us, and if you think about yourself working out, or if you're going to quit something, anything that you've attempted to change in your life, if you think about yourself, you know for a fact you didn't just go from point A to point B. You didn't make a decision and then just execute the next day, most likely. You probably went back and forth a little bit. So it almost doesn't matter to me that these boxes exist or which, what the definition of each box is, but the fact that the arrow goes both ways, I think that's the most difficult thing for people to internalize and accept and roll into their practice. So not being upset when a patient comes in, doing less well than they were doing when it comes to these motivational type things. So pre-contemplation, contemplation, people are beginning to think about change, preparation, and action. They're doing it. They maintain it. That's great. Your interventions should be tailored to your assessment of where somebody is. So if somebody's working on maintaining some change, maybe they've been coming into your office, getting viewed, they've been doing great. The kind of questions you ask them, the things that you want to work with them on are the maintenance things. How have they been holding it together? What do they want to continue to do to maintain their change? Somebody who's in a contemplation mode, who comes into your office, you want to weigh the pros and cons. You want to think about what their values are, what direction they want to go. You want to hear about their preferred futures. You're going to do different things depending on which box or which stage of change they're in.
I agree. I think that the kind of multi-directional nature of the trans-theoretical model is probably something that we don't highlight enough, and motivational interviewing really as a tool really lends itself well to pre-contemplators and contemplators and maybe kind of people early in preparation. There's actually some data that some of the techniques you use in motivational interviewing can actually do more harm than good if people are kind of far enough along those stages of change. There's also, I think it's important to recognize that assessing people's readiness for change and where they're at regularly is important, and you kind of can glean that information from your discussion with the patient. But there's also some data that suggests that the stages of change model in and of itself doesn't always predict whether or not somebody is actually going to quit based on what stage of change they're in. And I don't think that's because the stage of change model is wrong. I think that's because people move kind of back and forth among the stages so easily that it's, basically the point is don't rest on your laurels if you have somebody in action or even somebody kind of in maintenance. It's good to always kind of be aware of these things and be kind of reinforcing the progress people have made and looking for potential pitfalls, potential triggers, potential signs of relapse, those sorts of things.
And when you have this sort of, I'll call it a worldview, if you have this worldview, this change of worldview, and you're working with people, I think they're more likely to tell you what's really going on. Because if my patient comes to me who's been doing well for 6 months and everybody's been so happy with their progress and telling them, and they have some sort of relapse or some sort of problem, if they think that you're not going to be able to hear that, they don't want to disappoint you. They don't want to upset you. And I won't be upset or disappointed because look, man, nobody changes in a straight direction. It's no big deal. Like, let's just make a new plan based on where you're at. Do you still want to do treatment? Do you still want to, abstain from use? What's going on? To me, it's so much more helpful if a patient can just really tell you what's going on and not feel judged. It's less work. It's less work for me if I really know what's going on with my patients, and my interventions are going to be better because I'll actually know what's going on. So I guess I could sit here too long.
Right, we need to move.
We're running out of time. Okay, so here's some practical application stuff. The last few slides were kind of theoretical. Hopefully you're all still with me here. Reflective listening, engagement. So the way I like to think of reflective listening is it's my duty to prove I understood what you said. As a patient's telling me something, maybe they're emotional, something kind of serious going on, I'm thinking to myself, I'm going to give you a reflective statement. I'm going to prove to you I get it. That's my first job. I'm going to prove to you I get it. Reflective listening, one more thing about that, I think it's the most effective de-escalation tool at our disposal. I have yet to not have this work. Basically, I worked in a HERTZ program. It's like a mental health residential treatment. I worked 1 p.m. to 9 p.m. I was the only drug counselor, and I did the outing every night. So we had a 16-passenger van, and it never not worked. I mean, I had that population of people in the community 5 nights a week for 3 years. I'm telling you, it works perfect. If somebody is escalated and you give them a reflective statement, universally, they relax. I mean, I've never seen it not work. So I think reflective listening is probably the most powerful tool at our disposal in the entire toolkit. Mm-hmm. What do you think, Cam? Is there a way to overstate?
No, I think reflective listening is excellent. I think that oftentimes people assume reflective listening is simply just saying what the client just said to you. So if they say, I'm really pissed off right now, and you say, so I hear what you're saying is you're really pissed off right now, that might actually do more harm than good, because they're going to be like, yeah, I just said that. But what I think where reflective listening is really helpful, and what Nate was likely doing for it to work, was that he was getting a little bit deeper. Like if somebody said that they were angry about something, maybe he reflected back a slightly different emotion, but similar, like frustrated. Or maybe he reflected back that he understands why they're angry, because he can recognize that, yeah, I hear you. I know it's probably really frustrating that you wanted to go here, but the other 15 people in the passenger van wanted to go there. I get that. That's reflective listening. Just saying, if someone says I'm angry and you say, I hear you're angry, that's not reflective listening. That's just, that's what a parrot can do. So it's a little bit more detailed than that. And reflective listening, you can take risks with reflective listening. You can actually kind of amplify that response, and maybe take a risk to try to get at that deeper emotion or to get at the cause. And it's okay to be wrong, because if you're wrong, the patient has a chance to correct you.
Yes, that's key. It's reflective listening. Take a risk if you're sort of making the next logical step for them. Like, so what you're saying is X, Y, Z, and they're like, no, that's not right. The reflective listening still works. They got a chance to correct you. You love being corrected. They're the expert on what's going on with themselves, and you're there to hear it. So yeah, I love reflective listening. What does the client want? Why now? Another way to think about it. This next bullet point, the third one here, this is from David Me Lee, and I don't see him saying this as much now, but he used to say this. You can think of it like the patient is in charge of me, but I'm in charge of the treatment plan. So whether or not the patient comes to treatment, that's their call. What they identify for their treatment goal, that's basically their call. but I get to choose how we do it here. I get to choose the assignments. We're going to agree or disagree on how many days a week you have to come into the methadone clinic. So I have sort of purview over the treatment plan, but the goal or the thing that brings them through the door, that's theirs. So it's like a real respect for that is part of this. Some talk about clarifying the goals of treatment. You guys can, maybe that's something we could touch on some other time, but identifying goals and the importance of that. Some more tools in the toolkit, the miracle question. I don't know if you ever used this, Cam.
All the time.
Yeah, so this is from Brief Solution Focused Therapy. Another thing I've given a lecture on that I find super helpful. This is to get people to think about what they want in their life. Anytime you can get a patient to talk about what they want as opposed to what they don't want, you're headed in the right direction. If a patient comes in and says, I don't want to be depressed all the time, you have no way forward. You don't want to be depressed. That's like the absence of some, I don't know where to go. What does it look like if you're not depressed? How would you feel if you're not depressed? Oh, I'd feel happy. What does happy look like? Happy's getting up at 6 a.m. and going for a run. Oh, so do you want to do that tomorrow? Great idea. Exception-seeking questions. This one you can do with anybody, anytime. It can take, this is the shortest thing you can do, exception-seeking questions. Was there ever a time in the past where the problem was less bad? I'm not the expert. I'm not coming to you with the solution. I'm not giving you advice. What has worked for you in the past? I mean, I don't know why you wouldn't ever ask that question. I ask that question to everybody all the time. That's my favorite thing to do. Exception-seeking questions, the briefest intervention I think there is.
I think, too, is it gives you an idea of the patient's particular skill set, and you get a little bit of a glimpse into their current repertoire of behavior, and knowing what has worked for them in the past. Knowing if they can identify risk factors on their own, because that's your foundation. What's worked for them in the past is always, I work in primary care, so I'm always looking for simplest solutions first. And if there's been stuff that's worked in the past, that's where I'm going to start.
That they could do immediately.
Yeah.
Pros and cons, that's valuable. The discrepancy, we touched a little bit on that. You gave me that name to look up. If things aren't going well, point out the discrepancy between their goal and their current behavior. You say you want treatment, but you're selling your Suboxone. Tell me about that. Do you still want Suboxone in the clinic? That's sort of like that's the real end game right there. If somebody's behavior doesn't match their goals, highlight the discrepancy and reassess the goal. So for everybody who's wondering what to do when things really go off the rails, I think that's your basic game plan right there. And then in summary, because we're running out of time, I think these are my main things. Recall patients' goals, reflectively listen, pros and cons, focus, evoke, plan. That's the MI talk right there. The discrepancies, and be positive. I think there's no room to not be positive. Everybody has the possibility of getting better, finding more comfort, whatever it is they're looking for. There's nobody who enters the office who can't improve their situation, period. And have fun, stay authentic. Oh, and then a last little bit, this is one of my favorite things in the world, the great psychotherapy debate. So if you look at all the therapy research, kind of put it all together, this book, I don't know how to pronounce his name exactly, Wampold.
Bruce Wampold.
Extra therapeutic effects are the primary driver of outcomes. And that's why I think last week's Echo was so useful, because the woman from New York has this great plan of working with, or a system of working with these sort of extra therapeutic factors. I think that if you look at the research, it makes more sense to be working with some of the outside.
Well, to some degree, they've turned some of those extra therapeutic factors into almost a manualized based treatment approach. So they found ways to kind of lump some of those extraneous variables that are hard to define into a unified treatment approach.
I was going to mention this, but I didn't.
That's good.
And then breaking down basically the relationship is what is remaining in the sort of evidence for what works. So it's a big deal to have a positive working relationship with your patients. It's the biggest deal. And then lastly, I got a couple pictures from
our hike. That says the sun was about to set right before we got stranded on top of a mountain.
Yeah, that's Albuquerque. And I think if you're looking down from here, you can see
that's Mordor in the background.
University of New Mexico is right down there.
Yep. Oh, it's more. Okay. Yeah. Sorry, I forgot we were in Middle Earth for a second.
That's the motivational interviewing talk, ladies and gentlemen.
Any questions for Nate?
Please ask me a question.
Any comments? Or now you have to have something smart ass to say at least.
Or Elizabeth, I see you're smiling. She probably got something.
But I did talk to Dr. Olivas from Hennepin ER in the Poison Center. I don't know if you know the name, but one of the things that was a standout in the conversation was him saying that they have LADC coverage in the emergency department a huge part of the time. And that he saw that as a physician who's got an X waiver and prescribing and trying to move that ED forward. He said that's a service that we're not using. We're not using to the full capacity because of the skills that they have in.
We've had, I think there's a couple of grant funded LADCs in our ER, and yeah, I've been really interested in that. My work hasn't had me around there very often, but I'm very interested in that. Sounds like a lot of fun.
Yeah, and just kind of in general, like what you do, which is not, what you do is not what I'm sort of used to hearing and seeing, and it's been pretty exciting. So thanks for doing this talk, really.
Yeah, thanks.
I just want to say too, Nate, that I think motivational interviewing has been probably the most impactful tool that I've learned in my fellowship this year. I use it more often than any other skill that I, have learned as far as anything beyond the clinical medical information. And I had one more comment. I think your overview of it was really helpful to sort of get the set of it. And the only thing that's helped me get better at it is practicing it and doing it and getting it wrong and having my patients kind of giving me that feedback of like, you're not really going the right way.
Yeah.
And it was funny. One of my patients yesterday looked at me and said, "So you're a therapist, right?"
Yeah.
I thought that was kind of the best compliment.
The ultimate compliment.
Yeah, that's perfect, Alex. And I think you're a natural just to give you that compliment.
Yeah, I think too. It's important to. I in my talk at the boot camp I said this, but the way I think of motivational interviewing is it's like golf. Like you can never beat golf. You just kind of get better at it.
There's no
and
always improve.
And that's the way motivational interviewing is. You're never going to be awesome. Even the people who are best at motivational interviewing are going to stumble and kind of have bad rounds. And it's just a matter of whether or not you're able to kind of continue to work in the spirit of motivational interviewing that I think can have the largest impact. You don't have to get it right every time, and you won't. Sometimes you're going to fall on your face. And the important thing is that you kind of buy into that spirit of the model, and that's what will keep you moving forward. So great questions, great comments. Thank you. In the interest of time, I am going to move us forward to the case. Alex ran out of the room and came right back. So without further ado, I'm going to let Alex go ahead and present his case, and we'll go from there.
So I have an interesting case that came out of my clinic, and it's I think a really good primary care case because it hits all the different comorbidities that we will often see in a person that is actually not doing terribly. She's probably the best part of her experience has been with her substances, and everything else has been kind of not going well. At the same time, it's not been a straight line. So we can kind of hopefully see how I can hopefully get some feedback about, some of the things that could be better. But essentially the ultimate question is about this 28-year-old female is appropriately addressing her ADHD, which from her perspective is the most important thing to address. I first met her last year in July, right after she came out of an inpatient treatment for alcohol use disorder. She has numerous reports in our charts and further reports that she tells us about from having seizures and really horrible hospitalizations from alcohol withdrawals and intoxications. She came to me thinking, I finally am getting some decent mental health care out of this last treatment, and I know I want to get better at that. What do I do? What's wrong with me? I feel manic. And she had this notebook and all these discussions that she was trying to write out with friends, family, internally in her head. Our main focus in the beginning was on her mental health. She has a history of being on opioids, of using illicit opioids, mostly pills, and had been on methadone in the past, had weaned off in 2017. So a long history of different substance uses and addictions. Also had a history of benzo illicit use for self-medication of anxiety. She'd had many different attempts at getting her mental health under control, though when I saw her, she was only taking mirtazapine and using marijuana for sort of self-medication, basically smoking all day, every day, because she said that being high and depressed is better than just being depressed. And I tried to help work her through anxiety treatment, trying to pay attention of whether or not, she had bipolar disorder, because she felt manic and she thought that she was staying up all night and had all this irritability, and this was all consistent with bipolar and mania. She also was kind of going back and forth about not being sure what she had going on. The clinical picture was uncertain. My addiction clinic is in a psychiatry clinic, and my supervisor is a psychiatrist. So we did the primary psych management, although, that would be something oftentimes, I think, if I was seeing her in my primary care clinic that I used to work at, I would have had a psychiatrist helping me work on that side of things. Regardless, we went through a slew of different medications. Eventually, after many, many months of convincing her to start to take a mood stabilizer, she was improving with Abilify in conjunction with paroxetine. She had a diagnosed panic disorder. Throughout the whole process, we kept trying to get her to do intake for a dual diagnosis intensive outpatient program so that she could get ongoing treatment for all sides of her equation. She basically said, I don't want to do group therapy. I don't like groups. These people can't tell me anything I don't already know, blah, blah, blah. A lot of basically refusal to engage in what we typically look at as our standard of care for escalating care. Just this month, she finally agreed to see an individual therapist after I have been seeing her for 9 months. What else? I guess the only other important thing is that, she says the main sort of feature that she keeps bringing up over and over again is my mind won't stop racing, and I feel like I want to jump through a window, not out a window, but through a window. She very specifically wanted to make that distinction. She's also been seeing a primary care doc for different reasons. She's had her sort of physical health evaluated several times throughout these 9 months, as well as during treatment, and we haven't found any other physical contributing factors. We haven't really been doing any urinary drug screens because the clinical picture hasn't indicated, and she has not. She said basically, like, I don't want to use anything else besides marijuana. I know if I relapse, I die, all these things. And we even tried to get her on naltrexone for her alcohol use, and she wouldn't take it. She said she really just wanted to do it on her own without medications. So there was a lot of resistance to what changes we wanted to make based on her experiences with different things. And I've used a lot of the motivational interviewing tactic of rolling with resistance to help guide our treatment plan forward, which I think has led us to, she's definitely telling me she's doing a lot better from a mental health standpoint. She feels less all over the place. Her anxiety is better. At the same time, she continues to take illicit Vyvanse because she says it's the only thing that helps her feel like she can function in the world. And we've tried different non-stimulant treatments, and they haven't really, she said that they help her physical feelings of anxiety maybe, but they don't really help her mentally with her racing thoughts and her ongoing ADHD concerns. Her mom is calling, she's got ADHD, needs stimulants. And the most recent visit I saw her, she told me about this Vicodin use, which I think complicates the picture overall. She's
Alex, can I jump in and interrupt you real quick, Alex? Sorry. Before you get to that, the Vyvanse though, is there any evidence of harm from that? Just before we move on, from her illicit Vyvanse use, any harm anywhere that you could have detected? Any?
No.
Racing thoughts.
From the Vyvanse.
She's got mental health symptoms.
Okay.
So our discussion the whole time, and my discussion with her about stimulants is, if you do have bipolar and we're not really sure about that, we're still trying to work on that. This is going to make it worse, and I could do a lot of harm by prescribing you a stimulant when you're otherwise kind of unstable. And she disagrees with me and still continues to take it illicitly. And she has not had any reports of any harm or side effects or any concerns when she uses it. But I'm just basing that on her self-report. She's not had ER visits or anything else that's escalated care otherwise.
Okay.
So just the last thing that I was just wanted to touch on is the last visit I saw her, she's a PCA for a friend, and he wanted to dispose of his Vicodin. So she ended up taking those from him, using them. I think it was a dozen, a little bit more. She used it for what she said 2 to 3 days. Noticed it wasn't really helping her in any way. It just kind of numbed her out for a few days. And she said, I'm done with that. I don't want to go back to where I was in the past. So I don't want that. I'm not looking for it. I should have done a UDS to confirm that use was over, but there was, other factors that led me to not do that. So that's the plan for next time, is to start doing those more regularly. But otherwise, the question is how do I appropriately address her biggest concern? And what do you all have experience with in working with patients that have other comorbid psychiatric issues, not just substance issues, and working with stimulants?
Okay. All right. Well, I think.
Discussion.
So what I know that the folks around the table have some clarifying questions and some thoughts. But before we get to us, anyone in the ecosphere, anyone out there listening in that have any clarifying questions before we get to advice? Clarifying questions for Alex.
Kurt and Heather look like.
Kurt and Heather look like they're.
Yeah, I've got a really short attention span, so maybe I missed this, but was she ever diagnosed with ADHD when she was young? Do you have any records that would give you that idea?
She doesn't have records, but her and her mom both say that she was diagnosed and that's been a lifelong thing for her.
Yeah. Is there any family history of that as well?
I don't know if I've asked specifically about family history of ADHD.
Yeah. What's your educational status?
She finished high school, I believe.
Yeah. How about siblings? Any idea if anybody was college bound or parents?
Good question. I get the sense that it's not a. I get the sense that the answer is likely no, just based on the conversations I've had. But her vocation is carpentry, and there's a bad relationship that she manages within that. Her boss is her ex-boyfriend.
One last question, then I'll quit hogging it. What's the longest she's kept a job?
I don't believe she's ever had a true employed job, and that is one of her goals, is to be stable enough to hold down a job.
Great. Okay.
Good questions. Any other clarifying questions? Okay, what about around the table here? Helen, anything you want to know?
Yeah, Alex, thanks for presenting this complicated case. I think you've done a great job engaging her in treatment, and she's been able to share with you multiple struggles, which took a lot of courage to say all this stuff that she's been saying. My biggest question is, has she ever had a period of sobriety, like from everything?
Not including marijuana. This current run from June to, when she used those opioids, she was abstinent from all other substances besides the marijuana for at least 6 months before she started using the Vyvanse.
So she even in sobriety, she's still using marijuana. During that period where she was only using the marijuana, what was her mental health like? What were her symptoms like?
I think that statement of "I want to jump through my window" is the best way to encapsulate it. Very anxious, irritable, and sort of mood instability. She said she would actually lock herself in a closet because she didn't want to hurt anybody or sort of offend anybody around her, and she ended up not continuing to work because she couldn't handle being around the ex that she was working with.
Yeah. And would you say that a lot of her relationships in the past were kind of intense and unstable?
It sounds like it, yeah. And we talked about the diagnosis of borderline personality, and she actually brought it up. She's like, "Do you think I have this?" And I said, "Yeah, I think that's definitely a possibility." And so one of the directions we tried to go was for DBT therapies, and not necessarily to look at borderline specifically, but just to help improve her overall mindfulness and understanding of herself and to be able to deal with all of her co-mitigating.
Sure. Well, what's her relationship like with her mom? Her mom seems invested in her getting stimulant medications. Does mom have a history of substance use?
So she's actually, now that you mention that, I think I remember her saying that her mom may have stolen her medications in the past. There's definitely a long family history of substance use issues.
There it is, yeah.
And that's kind of the next question I'd have is, is there any legal issues?
I don't believe she has any outstanding legal issues.
Yeah, it might make it hard pressed for you to get kind of a straight answer on whether or not there was like any formal testing for ADHD. Another thing to consider is, I think in general, providers are getting much better at this, but there is kind of that long history of like diagnosis through prescription. Like, hey, we'll try this medication out, and if it works, you have that thing. And ADHD is no different. So those are medications that sometimes people, and historically, less so now, would say, and I hear this from patients all the time, oh, my pediatrician put me on it and said, hey, we'll just give it a shot, see if it works for you. And so you hear these things. And so it's very possible that she thinks she was diagnosed with ADHD, when in reality, she was maybe given something as a, I don't know, we'll just give this a shot and see if it helps kind of approach.
Yeah, I think that's a really good point, Cam. ADHD is not a diagnosis you're going to make by giving a trial of a stimulant and having someone's attention improve. That is an expected response to that medication.
It worked for all of us.
Yeah, well, possibly. But if you give someone, like Cinepril, their blood pressure is going to drop. That doesn't mean that they have hypertension. And so we're very strict about making the diagnosis of ADHD. And there's two really big components of that. One would be symptoms present and impairing before the age of 12. And so there's usually a paper trail. And I think the second part of that is reevaluate. Even if someone comes in and they had all the appropriate documentation, great evaluations, and they're sitting in front of me, I'm still going to be looking at how are they functioning right now? Is there significant impairment in function in multiple settings that I would say they still meet the criteria for this disorder? So that, and then also, there's so many ways to treat this that are evidence-based that are non-pharmacologic. Many times I don't think meds are helpful or the way to go, and we do all these other evidence-based things that are really helpful. So I can talk about this for a while, so let me know where you want to go.
Yeah. Any other clarifying questions before we move on to recommendations?
I do not know how to lower my hand. Kidding. So I saw that whole bunch
you just weren't getting the hint.
I saw the whole bunch of medications that she's been tried on and failed, of course. Has she ever been on any of those medications for at least, the 6 weeks, 2 months, while also not using substances? Like, did she give it a legit try?
Let me look at the list. Several of them, yes. My supervisor, Dr. Sheila Specker, is very much a stickler on that idea of making sure that we actually do appropriate trials of medications before considering them failures. So I would say several of them, yes, and several of them, no. Like the guanfacine, she only tried briefly, for instance. But the Seroquel, she's tried many times for different lengths of time. The Lexapro, we did give it a couple months. I don't think we have exhausted our non-stimulant ADHD approaches at this point. Mm-hmm. And I also, am very much wanting to explore those non-pharmacologic options that you were talking about, Dr. Wood, because I think, that is going to be the biggest sort of risk-benefit improvement for her.
Yeah. I think before I would try to rule in treatment for ADHD, I would also try to understand if we actually have enough evidence for that diagnosis. So again, it's looking at functional impairment in multiple settings. Mm-hmm. In terms of your question, are stimulants a definite no? I would say the daily marijuana use is a contraindication to prescribing stimulants, and that's just not rational prescribing with the setting of ongoing marijuana use. And that's a rule out for many of us. And so the UTAXs will help guide that, but marijuana can cause impairment and in attention and concentration. So I say that's a no-go from that. In terms of, she says her mind is racing. Is that an anxiety disorder? Is that her current misuse of stimulants? Sometimes in this setting, I'd say, I don't need to prescribe you a stimulant because you're already taking it. So if I prescribe something and you're already taking these two, are you going to stop taking these two? What are you actually taking? I think there's limited data to show that stimulants are effective in patients with a history of chemical use. When there was a good review in the Harvard Psychiatric Journal a few years ago, I'm not seeing data that it's super helpful. Certainly with the history of ongoing alcohol use, stimulants can be impairing and lead to relapse. And so we look at Strattera or a non-stimulant route. But again, I'm not seeing a lot of data that would warrant prescription of that at this time. And so when we talk about the evidence-based interventions that are non-pharmacologic, we're talking about mindfulness, yoga, CBT, exercise, sleep, and I think DBT, to Cam's point, should be at the top of the list.
And there's a lot of really good brief self-management strategies out there that really, if I break them down, a lot of them are basically time management, organizational strategies combined with physical exercise, assessing for sleep difficulties and treating any kind of sleep-related disorders she might have. Inattention in psychiatry is like dizziness in kind of broader medicine. It just because you have dizziness doesn't mean it's a brain tumor, and just because you have inattention doesn't mean that you have ADHD. Inattention is part and parcel with a number of psychiatric diagnoses, many of the ones that you're actually treating her for. And so to come up with that diagnosis of ADHD, beyond having to go back to prior to the age of 12 and having documentation like Helen said, I think it's also important to recognize that if she's not willing or able or to treat these other psychiatric conditions that she is presenting with and identifying as having herself, then we can't rule in ADHD if we haven't ruled out these other possible causes for inattention.
And EMDR, question mark?
EMDR. EMD. We might as well be talking about Freud if you're bringing up EMDR with me. So I'll get quickly. EMDR is an empirically supported treatment for a variety of conditions. I am not aware of literature saying that it is an empirically supported treatment for ADHD. The treatment for which it seems to be most effective is post-traumatic stress disorder, and I very much wonder about trauma history with her. It was one of my clarifying questions I forgot to ask.
Great that she's doing therapy though. It took 9 months, but that's okay.
Yeah.
That's awesome she's starting that.
EMDR, eye movement desensitization reprocessing therapy. Essentially, if you break it down and you look at the dismantling studies on it, it is essentially an exposure paradigm with additional kind of eye movement exercises and tapping exercises that are meant, the idea behind it, and I don't think this has actually been scientifically demonstrated, but the idea behind it is that it disrupts the kind of cognitive pathway between the traumatic memory and the current emotional response in a way that then makes people feel better. The studies would say that it doesn't, EMDR doesn't outperform prolonged exposure therapy. And so what that means is that if the eye movements actually had were an active ingredient in that treatment, it should do above and beyond exposure because it also includes exposure, and it doesn't. So I think why EMDR works is exposure therapy, and what people get better with prolonged exposure and EMDR is because whether you call it disrupting the cognitive emotional connection, or you call it habituation to to emotions, it's the same thing. So Heather and Kurt, you probably weren't expecting a soapbox from Cam.
That was a good one.
EMDR will put me on a soapbox.
Nice.
Helen, any thoughts about that specifically? I'm not sure of any
No, I think
on
the
ADHD.
therapist will help you uncover and clarify what the diagnosis is, and watch for that to unfold over time. I think Cam is right. Where's the trauma? And hopefully the therapist will go there. I think her use is evident that she's not tolerating and hasn't recovered from the bad things she's been through. But good job. Keep us posted.
Yeah, so just to kind of put a cap on it, she has mentioned PTSD mostly about her withdrawals and the medical issues she's had and I don't know what that means exactly, but I'm very concerned about that myself.
I think that means don't put me in withdrawal. Don't do anything that'll take away my substances and put me in withdrawal.
But her symptoms certainly make me concerned about that. And I think the other concern is that I have is that she did go to one diagnostic assessment for ADHD, and the therapist basically told her, we can't evaluate you because you are too quote unquote manic, based on the patient's response to questions about her childhood, which she got very inflamed and defensive when the therapist started asking her about her childhood. So my other question, just to see if you guys can have one more, how do we, non-psychiatrists, can we get her an appropriate evaluation? Is there a specific consult that you would recommend in these cases?
Well, I would keep working with her to reduce her substance use and chart that. We don't send people for neuropsych evals for ADHD unless we have a high burden of proof that they likely have it and that they've been able to maintain sobriety. So her best shot at, if her goal is to get on stimulants, her best shot at that is to demonstrate that she's in recovery and she's not misusing stimulants from other sources and that she's a reliable reporter.
Sounds good to me. That's kind of the tack we've been taking.
Yeah, good job.
Mm-hmm.
Well, thanks for the feedback.
Yeah, and it is 20 after, so great presentation, Nate. Great talk. If you guys have any additional questions, feel free to stay on the line. We'll hang out for a few minutes and help answer those. I know a lot of you probably have to sign off and get going back to clinics and whatnot, or shoveling or whatever it is you probably have to do right now. So we'll let you get to it. If you are shoveling, please stretch first and take it easy. And hopefully we will see you all back next week.
Thank you.
Thank you, everyone.
That's a great case, Alex.
Yeah, for sure.
Yeah, that's a tough one. The more you say, the more I keep thinking that borderline personality disorder probably encompasses a lot of her symptoms.
Yeah,
that doesn't rule out things like trauma. What's that?
Right.
Narcissistic personality disorder.
Yeah, both within that same cluster B of personality disorders. I think the fact that if she does have borderline personality disorder, there is a higher likelihood that she has experienced trauma in the past.
And DBT,
40,000.
DBT is not going to want to allow her to be on controlled substances.
Yeah.
They're going to want her to be sober and to learn.
Yeah. The other thing too is I wonder about her Vyvanse use and her Seroquel and like the way she likes Seroquel.
She doesn't like Seroquel. It knocks her out too much.
Oh, okay. Oh, yeah. Sometimes patients will report liking Seroquel when they're using stimulants because it brings them down.
Yeah.
Susie
I kind of played a little bit dumb because I really wanted to hear those, like that absolute contraindication with marijuana use for stimulants. Yeah. That was one thing I wanted to get out of this is like, what are those hard stops?
Awesome.
And I appreciate all the, the feedback, everything otherwise.
Yes.
Thank you, Helen.
Yeah. Thank you, Helen. Bye.
Bye.
Alex, I love that ACE score.
40,000.
Yeah.
That's not too low.
That's an old Dragon Ball Z reference. If anybody else is going that way with me.
Oh. Hey, Alex, I did have a thought, just kind of anecdotally, in drug court. If I think about the last 2 years, there's been people who have like failed out of several treatments and have done they've got one prescriber, the whole team, the POs, everybody is super paranoid about stimulants, all that stuff. There are people who have floundered in drug court where POs and the most skeptical people are like, maybe we should look at ADHD medications for this person. So even though they have raging, use disorders in other areas, or even people with stimulant use disorders, even the most rabid anti-medication crowd you might find will at times, if things don't seem to work at some point, they'll get on board and be like, we should try an ADHD med. We've tried everything. This person says they have ADHD. What's the worst that could happen as long as we have open communication with the psychiatrist?
Yeah. And then did you see good outcomes?
And this is anecdotally, yeah, I guess if I think about the 4 or 5 people who kind of meet that description, I think a couple of them have gone on to something like Vyvanse, like not Adderall, and have done well.
And I think I have a friend who's a psychiatrist in New York City, and he says he is probably the most prolific prescriber of stimulants in the city. And so he's like on the opposite end of the spectrum. He thinks that stimulants can help so many people who have all these different comorbid issues. It's hard to suss out what it is. And his idea is, this helps their function. And he sort of sets goals. He sets limits. He tries to manage it on his own. I don't agree with his scope, but I think that the answer is somewhere in the middle.
Well,
and
I think
collect perspectives.
I think Freud also thought that, but he didn't have Adderall at his disposal, so he just did a ton of cocaine.
I mean, Hitler did great with it, right?
Yeah, and so I mean that's what we're talking about here. Right? We're talking, yes, it's right. It improves your mood if you stay on. I'm just trying to think of the different recommendations here.
Thanks for bringing the case, Alex.
Oh yeah, no, I'm glad I got to talk about this one again because I've had like 3 different preceptors to work with, and everybody kind of gives different ideas, and so she's one that needs many minds trying to help in the right direction. So thanks, guys.
You're very welcome. Yeah, I know, that's okay. We'll get you. Are you gonna be back next week?
Oh yeah.
All right, we'll see you then.
And we're slow when you call in too, so.
Yeah.
Right on. Cool. Glad I made it work.
Yeah, cool, man. We'll see you soon.
See you later.
All right. Bye. And Val, I hear Angela and Brandon, and you're all on. Any questions from you guys? Or do they not know they're still on maybe? They walked away. All right, well, we're probably just going to hang up then. And if you need anything from us, you can always email Roxanne and get this out. Okay? Bye-bye.
Bye-bye.